discussing the legal, political, and social impacts of the World Trade Center disaster on the 9/11 responders. To start off with, I just want to welcome all of our online viewers. We have several of you out there, and I would like to encourage you to not only watch the seminar, but participate as you can, and submit your comments and your questions for our guests that we have here today. To start off with, it looks like Dr. Luft wrote a message to all of us as he can't be here today. So all of you can view it online as well as see it in the classroom. We reviewed it just a few minutes ago. But I think he brings up some very important questions for us. So I just wanted to highlight those questions. As he says, over the past few weeks, we have examined the issue of stigma and prejudice in regard to certain diseases. How is this reflected in both policy and the education of compensation? What is the role of the physician in providing unbiased expert testimony? How do we avoid compromising ourselves when dealing with emotionally charged issues where suffering is evident, but the data has not caught up the clinical reality in a statistically significant manner? He also encourages everybody to join in some of these vibrant discussions we're having in class outside of class. A lot of people pose questions and we leave and they kind of are out there in a vacuum, and some of these questions are recorded online, and we'd like people to go back to the site after class and after you've had time to kind of think about these issues and add your own thoughts and ideas. During this course, as we've been building on this experiment of using social media, using a website to integrate online participants with the classroom, we've been building it each week. This week, our goal is to start moderating some of the comments coming in and actually integrate them into the discussion. So I want to ask all of us here to help me with that. If you see something that's posted online, either on your laptop or on the projector, please raise your hand if you find it interesting. If you want to say, oh, so-and-so online has this really great question I just want to bring to the discussion, I'd really appreciate your help in that effort. The James Zadroga Health and Compensation Act of 2010 was passed in order to ensure federal funding for the health care and compensation of 9/11 responders. Today we are joined by several guests who will help us to better understand the bill and its implications for the responders. First, I'd like to introduce some of our guests here today. We have John Field sitting right next to me here. John Field is not only a 9/11 responder, but he's also a very determined advocate for the responders whose lobbying of Congress was instrumental in the passing of the Zadroga bill. I also want to introduce Fran Gottfried. Fran is the director of the Victims' Compensation Fund's New York office, and she deals on a daily basis with the complexities of this fund and its distribution. I also have next to John here, John Hewson. John Hewson is an attorney at law from Fusco, Brandenstein, and Rada. As an expert in disability law, he represents 9/11 responders for the Victims' Compensation Fund. And finally, I have Dr. Asha Karnik. Welcome. Dr. Karnik is a pulmonologist from the Long Island Clinical Center. He has worked many years with the 9/11 responders, caring for their health needs. He actually predates the Zadroga bill and the World Trade Center Health Program. He worked for this program when it was a federal grant known as the WTC Medical Monitoring and Treatment Program. So he offers a unique perspective of what delivery of care was like before and after the Zadroga bill. I hope you all had a chance to read the Newsday article yesterday regarding the recent research that came out indicating that there may be an elevated risk in 9/11 responders for certain cancers. And this article brings up a fundamental question. When deciding to cover certain conditions, what elements are required to make that decision? Does the decision need to be based in current scientific knowledge directly related to what we know about exposures and the aftermath? And if so, what should be done when science cannot provide the answer in a timely way? Can assumptions be made based on prior scientific knowledge? In the last class, we heard from many responders who expressed frustration, anger, in some cases embarrassment at having to basically beg, as they said, for compensation. And in deciding who gets health coverage and who gets compensation, one of the things I want to discuss today is what impact does it have on the responder? And to try to think about the responder's point of view and what they sacrificed and what they gave up, and how when they are looking for compensation, the reasons for why they're looking for compensations, and how do we deal with them as professionals, and how do we deal with these issues? Another question is it reasonable to wait for science to provide hard evidence of the link to exposure and health conditions while the responders are, in the meantime, debilitated, sick, and in some cases dying? How do we order the importance of what should be covered and what should not be covered? Do societal prejudices, do stigma inform our decisions? When there are limited funds available, can the money in healthcare be fairly distributed? I think that's a big question, is fair distribution and the perception of fair distribution. And then finally, what burden does the law and the implementation of the World Trade Center Health Program have on the physicians who must certify conditions as related to 9/11 exposure? How far should the physician go in order to advocate for patients? So I'd like everyone to kind of let these questions resonate with you. We're going to watch a brief film. It is from the 9/11 responders' testimony from the responders who participated in the oral history project with us. It's a compilation of segments of their stories around the theme of the legal, political, and social issues. And it runs about 15 minutes. So feel free to blog and tweet if you want to during the film, and just think about these questions as we watch.
The only thing I can say, and when I tell you I'm very loyal to the police department, I hope you believe that. I'm just disappointed what they've done to certain commands. And what I mean by that, there was the commands that originally, now I can't say first responders, the original responders that took the first hits in the brunt of this. What I do know is that word came down, not officially, but that they're all dead anyway, so just keep them down, they're working, and just write them off, and that's the end of them. And we never relieved, we were never allowed to transfer out of the area, and they worked us to death. They got as much as they can out of us, and then they said, you're on your own. And I'm very disappointed in that. But I guess that's the way things are.
after 9/11, did you continue to do any, recovery work?
I didn't work the pile, I didn't do recovery work. I blew out my rotator cuff. I had left surgery, shoulder surgery. I had both my knees reconstructed. I had back damage. I had lung damage, and I had cornea abrasions. My physical injuries kept me from working pile, and then put me on light duty, answering phones and doing what I could to help while I waited having the 3 surgeries. But as I said, I was in the vicinity because I worked at Canal Street, so I was in the air zone area. They had me continually come in there to that area. And what was interesting to me was, depending on my hours, if I drove in, when I had my car there and I parked down there on Canal Street where my precinct was, when I would come out, I kid you not, there'd be like an inch of dust on my car. And when I brought my car home, I would tell the children and my friends, don't touch my car. It was impossible to wash my car every day. Between the hours of working and going in, you were working 16-hour tours. They didn't care that I was injured and hurt and sick. They just needed everybody that they could. That's just the police department.
I was going to ask you, what were the conditions like that you were working on when you were on the pile?
Well, you were dealing with dust, instability of the pile itself, shifting and whatnot. You were dealing with smoke from fires. When you were finding remains, you were dealing with bloodborne pathogens, and so it was just one step to the next. There was some danger in everything you did.
Well, there was a lot of dust. There was a lot of dust. When I say lots of dust. But they had said that the dust was okay. So you weren't, thinking about wearing a mask because you had everyone there and officials was there without masks. So you know that, you had nothing to worry about.
They decided to give us these nice gas masks, not gas masks, but face masks. They had these 2 cylinders on the side because it was still burning and dusty down there. And then they told us we couldn't wear them. You have to have them, but you can't wear them. So it's just like that. He said, well, if you get down there, and when the civilians back in, they're going to get worried and they won't come back down. Or if they see you not wearing these masks, they'll think it's okay. I said, what about all of us? We're all that stuff, guys. Doesn't matter. You have to have the mask because the department is, but you're not allowed to wear them. I said, all right, what are you going to do? So we threw them in the car and left them in. After a while, we just left them in the water.
The respirator they issued us wasn't the right one. The canisters weren't right or something. The filters weren't the proper filters, so they had to take those back and give you different respirators. You have to understand that firefighters work on a principle of air quality. If I can see the air I'm breathing, I know it's not good for me. So if you can see what you're breathing, you know it's not good for you. So we expected, that there were going to be side effects. I don't know that I thought mine was going to be as bad as it turned out to be, but I certainly knew the air I was breathing wasn't good. And the longer you stayed, certainly the more exposure you got. It got to the point where you really couldn't be on the pile without a mask, because without a respirator. It's the ironwork and the steelwork, they're cutting, constantly cutting steel. Smoke was really bad.
The first 3 months, just going into the whole area there, the odor was horrific. I mean, as soon as you walked in, you got this heavy, musty odor, and you knew that it involved all these toxins from the rotation, they're biological, from, unfortunately, AIDS and constantly. And the first 3 months, it just lingered there. I mean, the smell never really dissipated. It slowly did. But
Sorry.
A lot of strays.
I'm really sorry about that.
Yeah, it's very difficult to ignore.
I'm sorry. I have to get back to arguing. We didn't see Ron yet, did we?
Yep, yeah, we did.
But we didn't really hear it.
We were at like 6 or 7 meetings.
Okay, sorry.
That's the guy.
this heavy, musty odor, when you knew that it involved all these toxins from the World Trade Center, biological, from, unfortunately, remains, and you were just breathing all this stuff in constantly. And the first 3 months, it just lingered there. I mean, the smell never really dissipated. Finally, slowly, it slowly did. But the people down in the pit didn't, for the most part, for what I call, they sometimes used paper masks, which really didn't accomplish much. We should have had respirators. They didn't. I feel that it's something that, I mean, obviously the health part of it, of course, is quite an impact, because I, at this point, have to go down to Mount Sinai Hospital 3 times a month for treatment. So it definitely had that impact. But even with that, it's something that I know I would have done in any case. I mean, knowing what I know now, the only difference might have been I would have been a little bit more careful, maybe with, asking for respirators or whatever, but nobody did that.
And I remember that first night, I mean, nobody really had masks. We had those little paper things, I mean, you were so burnt out, honestly, you just didn't give a shit no more. You just like, well, And then, then you hear, Chrissy Todd Whitman, oh, she took readings, the air's fine. Like, guys are coughing, like, all over the room, the air's fine. Come stand with me on the pile, okay, with this paper mask. You stay here with me until we're done here, and you tell me the air is fine. Go ahead, go have a sandwich, have a cup of juice. It's fine, you don't have a problem. Really?
We did not have the proper equipment the first day I was there, being September 12th. But I blame the government and the administration for the perjury, for the misleading of the population in utilizing certain detectors that did not show the imminent danger of the fallout.
Well, I was down there. They had all these air monitors on my machine and on my brother and sister machines and on us. And we asked for those results while we were down there, and we never got one of them. We always got an excuse, but never got any of them. Yeah, I had them on me. I had them all over my machine. We all did. They had monitors all over the place. I don't know one person that ever got a result. And we became friendly with the guys. One guy's name was Dan, and I don't forget his sidekick. But anybody that was down there know the 2 guys. They were the monitor guys. And they were nice enough fellows, but they worked for the government. The government was covering everything up. The government knew that the air was bad down there when they were telling us it wasn't. They looked at us like they were guinea pigs.
Now, we're at the point where we have to wait for the Senate to vote on whether they want to compensate the guys there for medical coverage and to compensate us monetarily for the stuff that we did down there. There's a lot of stuff that goes on, that's being said in politics. Well, why should I lay that money out? That wasn't my state. Really? But if it was, how would you feel? These guys are, they have our well-being and their future. They don't realize a lot of these guys are too injured to go get the job that they always wanted after they retired. You're too sick to, or you're mentally not able to. But now that it's this long had passed, we didn't go away, and more of us are dying, and more of us are getting sicker. And now they don't want to know if they want to do this. They don't know whether they want to support us or not. They don't want to know if they want to take care of us. It's a shame. You know? I wonder how they would feel if they were with us every morning, getting on that truck and breathing that crap in and pulling up bloody shirts and fingers and arms and everything else till January. How would you feel then? You feel like you want to be compensated? You know, guys aren't asking for anything that they don't deserve. They're not being greedy. Take care of us. We didn't ask any questions. Well, wait a minute. Before we go into the pile, we have a checklist of everything that we want when we're done. The guys are feeling very betrayed. All of us. You know, I hope this thing called the Draga bill goes through.
I see it from the charity work that we do, how hard it is to get people to come out, how hard it is to get even the bare minimum of media coverage. You know. We go down to Washington and meet with the senators and congressmen and their aides. And you're totally amazed at how little support there is sometimes for 9/11 issues. We like to call ourselves the 9/11 community, but it's hard, and I certainly haven't been at it all that long, but the people who have been at it for a long time, I'm amazed that they're still doing it, because when I go down to Washington and I see, what they have to deal with, wow. How do you keep doing this? Why do you keep coming back? But they do, and if by doing that they could manage to help 9/11 survivors who are sick and hurting, that would be great. I think we can do that. I think we can, garner enough support to get a bill passed, hopefully. But again, history will tell.
It's been almost 10 years now, and a lot of people are dying. There's over 1,000 responders now that are dead. It'll be, by the time this gets all aired, there'll probably be hundreds more. At the time, I didn't think I was really affected by it. I always thought I was pretty indestructible. Evidently, basically destroyed my life, 9/11. I don't like to use that because I'm a half-full type guy, but it has definitely put a lot of strain over the last couple of years. Definitely on it with my health. But even before that, you can only think back on things. It's too bad you can't think back on it while it's happening. You can't because it would be easy to put things back in place. But you can't put things back in place, so you learn.
So what did people think about the video? Do you have any initial comments or what struck you?
I do.
Okay.
I've seen the video before. I'm actually, I believe, in that, right?
In this one?
Not in that, but
yeah, not that, in that clip, but in the other.
you hear the raw emotions of these men, but you also hear the visceral and the anger and the hate, but their facts are raw. And while one of them traveled to D.C. a couple times with us, and we made over 100 trips to D.C. in those 8 years, in the 9/11 community, there's often a lot of anger and a lot of visceral, because they're not getting the facts. And the facts, you know, the phone tag game. So if somebody says something, it gets, by the time it gets to that responder who's last on the list, it gets blown out of proportion. And what you're seeing there is a classic example of while they're sick from 9/11, they also think they know what's going on in everybody's house and what's happening in DC and in the city, and it's just not the case. So we at the Feel Good Foundation, we try to disseminate the correct information. We're often found ourselves backtracking and fixing other people's mistakes, and also either advocating for or against law firms, no offense to law firms, and also advocating for the BCF, who's doing a great job. And I'm not saying that because Fran is here. I'd be the first one to say they're doing a horrible job. So, and I don't say this to be pretentious, but it starts at the Feel Good Foundation in the 9/11 community, and it's works its way out. But while this was done a few years ago,
Yes, how long ago were the videos taken?
Right, so as you could tell from the language included, we utilized these testimonies for an earlier session of this very same course. So we had created these video montages and had used previous interviews, so it all precedes 9/11. Actually, most of those people that you saw were actually interviewed during the time that the 9/11 Droga bill was in discussion. So there was a lot of tension in the community and a lot of uncertainty and a lot of investment on the part of responders going to Washington and hoping that someone would hear their story and actually understand their predicament. So you can kind of see that in the people here that were interviewed, that anxiety, that fear, that sense of being betrayed, because there was a lot of uncertainty at that time. Whereas now, which is something we can get to later in discussion, now that the bill has been passed, you know, how are things different, or are they, with how responders feel?
The reason I was asking, actually, Mr. Field, is I'm wondering how soon after the event did you see there was anger, or you refer to something visceral? I don't know exactly what you mean.
after the event, you mean right after 9/11?
How soon after the event did people start feeling the way they felt in this video?
No, there was nothing but patriotism after 9/11. If you worked on the pile and if you were directly in that 9/11 vicinity, cops, firefighters, construction workers, we were one. We were united. When you came in and out of Ground Zero, West Side Highway was crowded with ongoers, cheerers, giving us food, gloves, masks. I never saw anything like it in my life. I think as we went away from that, the media sensationalism and not fair and not balanced journalism caused a lot of hate between religions. It was about religion. And I think that's carried on. I think because of poor leadership and bad politics since 9/11, we've gone backwards. 9/11 surely taught us. You know, let me take you back. This country is founded on volunteerism. Volunteers came together in 1776 and we fought for our freedom, basically, right? So the single largest act of volunteerism. 9/11 is the second single largest act of volunteerism, ever. You can't find another, you can't think of anything in history. So we all came together because that's what Americans do, and that's what makes America great. Not our government, but the people. And those three men in that video, they shared that on 9/11, 9/12, 9/17. But as we got further away from 9/11 and the facts weren't presented to them, it created a lot of havoc in the 9/11 community. There wasn't a person in the 9/11 community that thought the bill would pass. Not an elected official. Everybody said the bill was dead, it was flatlined, it will arrive on the floor and it will get shot down. And it did get shot down. It got shot down twice before we actually got it passed. So never once did me and my team say we couldn't get it passed. We always said we would get it passed. Never once in my mouth, came out of my mouth, I thought it would fail. So
you're saying in the political community nobody thought it would pass? What do you mean, all the American public?
Everybody. You know, listen, we met with every member of Congress and every member of the Senate over an 8-year period. You know, not only did 9/11 alter our lives, but that almost full decade took its toll on us. But when everybody disappeared that last month to go on vacation or just gave up. We were there at the finish line, and I gotta believe we willed it across it.
I want to interject. I see that on our, someone watching online, Captain Joe, I guess I posed the question of, how have things changed, and he commented here. Regardless of who said what to who, the fact is that first responders ran down to the Trade Center without being told to go there. As a first responder myself, we are all victims in one way or another. Zadroga has been a big help, but people tend to forget with the passage of time. Funding must be secured now for the future.
I think that's the biggest thing that I take away from working on these cases for so many years. Time is a double-edged sword. We like to say time heals wounds, but time also forgets the wound as well. I tell a lot of clients when I talk about these cases that it's a very difficult scenario to massage the travesty and the victimization that occurred on September 11th of 2001 with the fact that as time progresses, I have a 3-year-old son. When he's my age, September 11th, 2001 likely will not mean the same thing to him that it means to me. Think about how, me being in my 30s, medical students, think about how we think of December 7th of 1941. It's kind of this double-edged sword that we have to fight against. There is a very, very important factor that needs to be addressed, which is that, look at this article from Newsday. The median age of responders is 38 years old. This is a problem that's going to go on for decades that are going to need to be addressed. And so when Congress does a great thing by passing the Drug Act and funds things through 2016, 2017, it certainly addresses the issue in the short term, but what are we doing to address the issue in the long term? And I think that that's going to be why there's going to be an ongoing battle. That's why John is going to be working for years to come to continue this fight. It's a major, major issue.
I have a question.
Sure.
Just to that point, many exposure-related cancers, such as mesothelioma and lung cancer, they don't even appear until 30 years after initial exposure. So,
right.
Has there been funds? Is that recognized among the Field Foundation?
Let me. We're not going to wait till 2016 to start lobbying to keep the bill open. We'll start in the middle of 14 or the beginning of 15 and go through the whole cycle again. There's a good chance of compensation clause. Depending on who controls the House, Republicans or Democrats, it all depends. I highly doubt that the compensation will ever be renewed again, but it could. It could be down the road. The healthcare part of the bill is always going to be up and running. That's going to be a slam dunk. We'll keep that up and running 15, 20 more years, and you will have the asbestos cancers coming down the road. Keep in mind the city still sits on about $700 million from the lawsuit, so they're waiting for that next wave of cancers. So yeah, it's an ongoing battle. Right now we're in D.C. for the last month, Glenn and myself and others, to try to stop the sequester on our bill. So it's always something. So whether it's getting the bill passed or getting cancer added to the bill, which took 2 years, there's always something to the bill that we have to fight for to keep it intact, so it helps as many people as possible.
I wanted to, comment you asked about the film,
right.
Just
right.
in terms of the project of, creating documentary history. So, from a social science point of view, I mean, John's comments are, well taken in that, everyone has their value system and, commentary on how they see things. And from a limited perspective, they may not know the whole. But, as John Houston says, not that long from now, people forget. And the notion of creating these tools to remember is, valuable in history. And, just again, John, you was talking about volunteerism. On the way over here, I actually am sort of in the midst of listening to the biography of Benjamin Franklin by Walter Isaacson, and they're talking about volunteerism. So you know, anytime we all, you know, in school, college, you read history, you know, you have to recognize that whoever is doing that makes a decision about what to include and not to include.
But if you ask every 9/11 responder, if you take a survey, and they'll say, well, most people moved on and they forgot about us. We're human beings.
Right.
Our natural reaction is to move on. You can't fault anybody for getting on with their day, whether they're doctors, lawyers, or working CVS. You have a life to live. It doesn't mean you forgot about 9/11, but 9/11 responders feel like they've been abandoned by the masses because people have moved on. But then you take Boston, and devastating as it is, you can't compare Boston to 9/11 on the scale, but you can compare the attempt to hurt and maim people, and that reminds us of 9/11, and it brings us right back to 12 years ago. And yet, you know, if everybody knew as many people as we did in the 9/11 community, you knew that PTSD was on steroids on Monday. This whole week, a lot of people, we called 911 on a couple of people to have them locked up because they said they were going to hurt themselves. So when you get these catastrophic events after 9/11, it brings us right back to 9/11 where everything's compared to 9/11. So
I think there's an important question, again, I want to bring in someone from online, to deal with kind of what Fran was getting at with this issue of also trust. Like the trust that in volunteerism, when people volunteer, they have some sort of expectation or trust that they're going to be relatively safe in that environment. And 9/11 relied a lot on volunteers, not just the paid professionals. EL writes, when the government does not provide accurate information at the get-go, how does this impact the integrity of future information? How does it impact people's trust? Does everything become political? Isn't this the greatest risk of untruths? It undermines the proper working of society and justice itself.
no, and there's got to be a time frame on that, because after initial attack or an event caused by Mother Nature, a volunteer is doing something spontaneous. So at that moment, you bought your ticket, you know what you're getting into. So you can't blame anything on the government or Mother Nature or the terrorist attack. You're doing something because you feel compelled as a human being. As human beings, it's our job to feel other people's emotions, whether if she was happy, I feel happy for her. If she was sad, I feel sad for her. When there's an event, we rush into it, but the time frame, well, with 9/11, should have been, or maybe September 16th when Christy told women lied. Then we knew it was a lie. Or at Boston, you saw everybody, the volunteers that ran in when Boston was attacked. If you ran right there, you can't blame anybody but yourself until you know different. So
I think this issue is getting at this when the government made a statement, right? There's an official statement.
But history repeats itself. Everybody knows the government lies. You can't be shocked or surprised anymore.
I mean, I kind of come at it from the angle that I think that at least over the last decade, 12 years, you know, these 9/11 questions may be our greatest ethical and moral dilemma, not just from a political or a socio-political aspect, from a legal aspect, from a medical standpoint, because at some point, you know, it's human nature that we have to draw lines in the sand. We have to draw lines in the sand. On, you know, at what point, you know, we're going to probably talk about, you know, the medical ethical issues. You know, from a legal, you know, from a legal perspective, every day on these cases, I deal with the legal ethical issues, and then you deal with the moral question of, you know, we know what happened. We have empirical evidence that supports ongoing treatment. You know, why does politics wind up getting involved in it? And it naturally does. And that's why we constantly, you know, are fighting with each other over and over about this. But there's not a simple answer on any of these questions. And that's why we have, you know, symposiums like this. Because, you know, in my estimation, at least, you know, from my perspective, at least over the last decade, the questions that this disaster poses probably are our greatest moral and ethical dilemmas that we face right now.
I'd like to segue into one of Mary's questions that she's one of our student leaders here today. Regarding WTC health and compensation coverage. And why, you know, trying to understand why certain conditions were covered and others are not, especially in terms of compensation. So, Mary?
Post-traumatic stress disorder is a common condition that many first responders developed in the aftermath of 9/11. Yet suffering from this potentially debilitating illness does not make the individual eligible to receive funds from the September 11th victim compensation. Is this fair? And should funds be reserved only for those with physical illnesses?
Frank, can I answer that first?
Oh, you, oh, sure. I was.
Don't make my post-traumatic.
Go ahead.
Go back to the first VCF, because there was one in 2001 and 2, run by Ken Feinberg. If you went in front of Ken Feinberg and you had asthma, you got $50,000.
Is that a doctor, this man, or a
Ken Feinberg was the administrator of
Special master of the first fund.
A special?
He was the special master of the first fund, the victim compensation.
You got $50,000 for asthma, and just using average stuff. But now, say you went there with just post-traumatic, you got nothing. But you went there with asthma and post-traumatic, you got $75,000. The post-traumatic accentuated your other illness, and you got compensated more. And that was Ken Feinberg's way of doing things, and that's how he dealt with the post-traumatic. The thing is, yes, post-traumatic should be compensated under this bill. I'll say that till I'm blue in the face, and Sheila knows where I stand on that. In 2006, the Surgeon General said post-traumatic is a physical injury. And here's what we, besides cancers, post-traumatic is the #1 killer of 9/11 responders. And I say that because physically and mentally it breaks down your immune system while you're trying to fight your other illnesses. And while you're dealing with respiratory illnesses or cancer, your immune system becomes compromised because of the stress. The stress of being financially burdened and not working since 9/11 because of your illnesses. So yes, it should be. But I think Sheila and her team have been fair. And I think if you went there with cancer, and I think if you went there with asthma or some sort of serious, and you had post-traumatic, I think they're going to take that into consideration. Also, the way the bill is written, it's really making sure that those who work on the pile directly and those who worked in the surrounding area directly are compensated and given the proper medical treatment on the health care side of the bill to get the best possible care and to be compensated. And geographically on the healthcare part of the bill and geographically on the compensation part, there's two different mats on it. So does Bob Smith, who lived 8 blocks away, deserve to be compensated for just post-traumatic because he saw the plane? If I saw a cab hit a person and the person's head exploded off his shoulders, should I be compensated because I saw it? So I think it's really a safety net for the 9/11 responder community. And that's me speculating, but I'm usually always right.
So, you know, maybe it's, you know, it's worth, you know, just taking a couple of moments to you know, do an overview, explain essentially what the victim compensation fund is. So there's a DROGA Act. There's 2 parts. The bill. It's Title I is the World Trade Center Health Program. And Title II is the Victim Compensation Fund. Someone's up. Right. That's true. We're looking at the blog and going in at the same time. So, and just to be clear, the fund is working, you know, very closely with the World Trade Center Health Program and with NIOSH. And so these synergies are really important. I'll talk to you about it for, you know, in a moment. And, you know, I just, you know, want to, you know, thank you for inviting us here today, because, I mean, just myself, on behalf of myself and Sheila Brumbaum, the special master of the fund, just the New York office focuses on outreach. We do, you know, legal assistance clinics with the city bar, do other kind of information sessions. For example, you know, we're here today, but the fund is administered under the Department of Justice. Most of the people are working in Washington, but decided to set up a New York office this time because everybody is here. And at such point that there would be appeals and hearings, those will be in the New York office. Again, just keeping in mind that there, are, individuals, claimants who will apply through the Shanksville and the Pentagon sites, sites as well. So, the fund essentially implements the bill.
Okay.
And there are just in terms of the eligibility, component, and I have some material for you, after you could read up more about it. The eligibility component, focuses on, what are the qualified injuries. And so the qualified injuries are, well, physical injuries, because that's what the statute says. Now, the physical injuries initially, we have the list, right here, as focused on, a lot of, respiratory, GERD conditions. And then cancers were added on October 12th, 2012. And the fund determined that in order to kind of make things logical and, efficient, if NIOSH added a condition, then the Victim Compensation Fund would add those conditions as well. And that's why those funds were, certain cancers were added. Should another condition be added in the future, a physical condition, the fund would most likely include those as well. So there are the injury requirements, the time frame of exposure, to the site, and location. I mean, just for example, if someone is a resident, the exposure zone is below Canal Street. And this is but all in the bill and the rules of the fund. So, and then there are, rules that relate to filing in terms of meeting deadlines, which are particularly important. We're going to be doing more, public service announcements in the near future because I have, again, these filing deadlines for you, but it's really important that individuals register. If someone knew that they had a condition, were treated for a condition, or should have known that they had a qualified condition before the day that the fund opened in October 3rd, 2011, they have 2 years in which to register.
Let me just interject for one moment.
Sure.
What people don't seem to realize, and that's why there's going to be mailings during the summer and a huge push this summer, is because we're already 2 years into the VCF. Yes. This isn't something that just came down the pipe.
Right.
The fund started on October 3rd, 2011, so everybody who had asthma, COPD, reactive airway disease for the last 10 years, they have until October 3rd of this year to file. Otherwise, based on the statute,
they're
out of luck too.
Right. Yeah. Now, the intention of of the fund is to try to make it as transparent and easy as possible. Having said that, as John knows, there's a lot of information that's required to implement it appropriately, and one sort of change sort of initially in order to fulfill the filing deadline, individuals had to file the eligibility form, but in order to make it easier, people essentially they have to register by these deadlines. And then the fund is open until October 3rd, 2016. They really have until that time. Let me just...
Because I'm confused. So if you develop a condition after the
filing date? Let me give you this quick overview. And just add on the cancers for a moment. So the cancers were added as a eligible condition, these certain lists of very specific cancers, on October 12th, 2012. And so for an individual who knew that they had the condition, were treated for the condition prior to the inclusion of the certain cancers, they will have 2 years from October 12th, 2012, which would be October 12th, 2014. Okay. Should someone become aware today that they have an eligible, condition that they didn't know about, and I'll talk about, BCF1 in a moment, then they would have 2 years from today. So this is April 24th, 2013. They would have until 2015.
Now, along the lines of what the gentleman sitting to your left said before, conversely, if they get diagnosed on April 24th of 2018, the fund is already closed.
That's right. I mean, that's, again, this is the statute.
How much money is in this fund? How many people have been held?
Okay, so remember, this is, relatively new. Let me just say how much money that the overall allocation. Again, remember, this is from Congress. Is $2.775 billion, including administration, and so the object of the fund is, frankly, to keep the administrative aspects as streamlined as possible, because those funds come from the funds. We're very conscious of that, and I'll say in a moment, we're in the middle of recruiting hearing officers for appeals who would be non-paid hearing officers. The special master is pro bono, is not getting paid for this at all. And then there's the eligibility and compensation forms, which people could fill out alone. We have legal assistance clinics. Having said that, there's work attached to it. Now, under the bill, if someone retains an attorney, the maximum fee that one needs to pay is 10% of the award. We're at the point where that we do, recommend to people that they retain attorneys. The fund is not in a position to recommend attorneys, but we've tried to work closely, with the attorneys. Where I don't know, John, if you've been in touch with anyone, yes. But yes, but in trying to make it as seamless as possible. And so then, just to give you a sense, the compensation piece of it, there are a couple of, so at 2.7, let me come back to that.
Just for the
VCA. That's the victim compensation fund. However, in the first 5 years, the $875 million is set aside. And so if a loss calculation is determined for an individual, an overall calculation, their initial payment would be 10% of the entire of their potential award, because we don't know how many people are going to apply and what the eligibility is, so in order to maintain the funds.
I have a question,
Sure.
Just to go back to the PTSD question in relationship to this. Do you think that because there's limited funds, that's one reason why mental health issues were not included?
Well, I mean, again, we're, implementing the statute, and that is what the statute says. Having said that, again, there is an appeal hearing process where individuals could come, and making it very clear to potential hearing officers This is not an adversarial process. You know, just for our earlier conversation, there are people who come, we're very sensitive to the notion that this is, you know, a sounding board.
It's not money. You gotta understand, when the bill was first written, the bill was a 20-year bill, and it was $10.5 billion. As we went over those 8 years, the bill got chopped up, and wound up being 5 years.
I think someone online is asking basically that question. You know, the master was fair, who was unfair, and why? Why was the bill written that way? The physicians know and the responders know that PTSD is most devastating. Why was the bill so poorly written?
No, I think the reason may be, I'm guessing, but if you put yourself in the shoes of a policymaker, the distinction between physical and mental health to me is completely shocking as a physician, because it's rare that you find someone with a mental illness that doesn't have a physical illness, and it's rare that you find a physical illness that hasn't had a mental impact, whether it's something like osteoarthritis or diabetes or heart disease. But PTSD carries, I think, very major consequences for our military servicemen and many other kinds of public personnel, but military particularly in this last decade. And I don't think that I have never thought about the concept of volunteerism the way you described, so that's very useful. But it reminds me a little bit of what I've heard about PTSD and how it was not addressed in previous conflicts that involved American soldiers before close to when I was born. So I wonder if that may be a reason. They feel it would be opening up a Pandora's box.
I mean,
PTSD is currently covered, though, in the VA system.
Under the health.
Correct.
Under the health,
Correct.
the health program.
And under the health program, just the
Right.
compensation.
Yeah, the treatment for it is covered, but not the
Not the compensation.
and
not
the
to
way
and not to
the way an
distract.
amputation might be, or the way something
Right.
else might be.
And not to distract from the discussion on the VCF, you know, the VCF is one component to compensation that a lot of responders
Right, I
are entitled
understand
to.
that, yeah.
So it's kind of an interesting, it's always an interesting discussion from a disability law perspective, because the VCF is only one component to a lot of different things. So the
Right.
VCF doesn't compensate for PTSD, but I may have a lot of responders who get a pension because of it.
Social Security disability.
Social Security
Right.
disability because
Right.
of it. May get workers' compensation because of it. So it's kind of like this, and to answer your point, I personally don't believe that, you know, from a socio-political aspect, we really have a good gauge on mental illness as of yet.
We do or we do not?
Do not.
In medicine or politics?
No, in politics. I think in medicine, I think that we have a fairly, you know, substantial amount of empirical data that backs up the, you know, the positions of people that represent or speak on behalf of first responders. But I think that from a society's perspective, I mean, we could see it with the gun issue. You know, there's a major push for, you know, mental, you know, we don't have a good gauge on it yet.
Yes.
You know, Vietnam vets, you know, kind of got pushed to the wayside when it comes to post-traumatic stress, and they've suffered with post-traumatic stress for 4 decades at this point. It's a dangerous slope for a politician, but for practicing medical physicians, it's really not that much of a discussion in their minds.
But, you know, I just want to say, first of all, you know, John Feel a Good Foundation, you know, the people that, you know, John went to Washington with are so instrumental.
Oh, yes, that's what I
in
wanted to learn
just
about
been fantastic job in making this happen. And, you know, should there be a change from a, you know, congressional point of view, obviously we would implement it. I just want to add, you know, one piece that relates to the health program, and then and move on and be glad to answer the questions. So I said we work very closely with the health fund, and one important piece is that in terms of certification of the conditions, that we are working very closely with NIOSH, and depending upon, you know, NIOSH to certify the conditions, and so the fund will rely on the certification of those physical conditions, you know, by NIOSH. And so the role that, you know, the World Trade Center, you know, health programs are playing are really critical, because again, from the point of view of the fund, we don't really want to have hire additional medical people and spend the money when they're doing it. So
Keep in mind,
we're
NIOSH
working really, I mean, we work really closely together. We've been doing outreach. I mean, just, and, you know, say something later on the
NIOSH
medical doctor.
and the BCF have they're damned if they do and they're damned if they don't, because they have to answer to the 9/11 community, who again, without the facts in front of them, can spew visceral or hate and anger. But NIOSH, who's doing a great job administrating the health side of the bill, and the BCS is doing a great job on the compensation part, the New York delegation has to go back to Republican leadership and show them the numbers and show them that the bill is running smoothly, so we can use this as a chip to renew the bill in 2016. So this is vital. Again, there's a lot of moving parts to this. You know, when the bill first passed, if I took 10 lawyers and put them in a room and put the bill in front of them, you'd have 10 different interpretations of the bill. The bill was not black and white, it was gray and it was fuzzy. And
I have a very basic question, because I've never seen a bill. So I'm assuming it's a document.
Sure.
And is it doctors that sit down and write, these are the diseases, this is what happens? Who says,
no, it was,
what,
the,
how do you,
the bill was
what,
written by elected officials and their staffs, and they took you know, input from you know, the medical community, the scientific community,
the people
and the
affected?
facts and the stack, how many people worked on the pile. Yeah, you know, when we were trying to get the bill passed, a lot of elected officials would say, well, this is a New York issue, why should this concern me? And I don't like to use the word lobby. We educated these men and women from Minnesota or Texas or wherever. But we educated to the point where there's 435 congressional districts in the United States. 430 of them were represented at Ground Zero.
Wow.
Somebody from every state came to New York to help during the cleanup and the recovery. Wow. So we had to throw that in their face. And then we broke it down to, well, how many people were from that state? And then we let them know, well, you had over 1,200 people from the state of Mississippi that came to New York. So again, it was little steps all the time, but it was a lot of moving parts for everybody to come together, the advocates, the 9/11 responding community, the survivor community, the law firms, the elected officials, and I truly believe after 12 years we're finally almost, not 100%, but we're close to being on the same sheet of music. And that took a long time.
I have a question for Fran, if that's okay.
Sure.
I'm the wife of the first responder who was shown there. He's actually at a consult with a surgeon for another 9/11 related illness. And I'm also a psychotherapist, so there's a piece in this that I wanted to ask you about. The amount of work, the amount of stress in gathering medical records and going through all of the process has been so voluminous, so reactivating.
Right.
I do not know if we're maybe not working with the right attorneys, but the information that we've received, my husband, in terms of exposure, was on the pile from September 11th until the middle of January. His role was to be tied off and lowered into the rubble to attempt to assist in attempted body recovery. He was doing that for over 4 months. He has been diagnosed with respiratory illnesses, with GERD, with RADS, and on from there. When they told him what a likely compensation was going to be, it was tremendously less than you would expect in a car accident when you had a broken leg. What that did in terms of reactivation for his trauma was huge, because it's almost like on some level it would have been easier if it didn't exist, if the bill is not going to do something that feels at least symbolic of a real compensation for what's happened here. So how would we go about finding out whether those numbers are correct and finding out what is real for us in terms of what we may expect?
So what's your name?
Cindy.
Cindy, sorry.
Because the not knowing continues the stress and exacerbates his PTSD.
So, understand. Is he represented by an attorney?
He is, but it's been very vague at best.
So first of all, the compensation components there are a couple of components. I mean, one is economic loss. And that's, you know, could be out of pocket, you know, medical, you know, it could be medical, it could be other assistance, you know, issues. What could somebody do, you know, not do that they used to do, whether it's, you know, is it that someone used to paint their house all the time and they can't do that now? But of course you have to show that you've done it before. But, you know, a lot of medication that is not, you know, obviously not covered by, for example, you know, insurance. And then there's non-economic loss. And that would be, you know, determined in terms of categories. And that's, there will be set amounts as there were in the first fund, depending upon an individual's particular situation. The third component would be collateral offsets. And that is, depending upon the individual, if they have pensions or other benefits that are where they've been paid, those would, again, in general, because I want to talk about the individual's situation, would then generally be deducted. Now, in terms of the difficulty that individuals face in gathering all this information, so one of the requirements in filing these eligibility forms is there are requests for you know, certain affidavits and attestations to give us the fund releases so that we could get information. We've worked out arrangements with the New York, you know, the fire department, the police department, Social Security Administration. We're trying to complete an arrangement with, you know, NICE in order to get certain information. And the medical from, again, from NIOSH. I should add, so that if someone's certified by NIOSH, then it's clear we get the information. There are individuals who are being treated by private physicians. So, you know, there's a form that's going to be, you know, online, again, to get the release from that individual, and the physician form would be filled out. And again, we're going to have NIOSH do that certification.
Once that's gathered, because his stack, I'm not exaggerating, is to here. If we're not getting the answers we need from the attorneys, is there another recourse?
Well, it's, you know, if someone, and I, you know, I have the material for you after. I just, we have, again, in trying to keep this sort of open from the beginning, we created a website that's fairly dynamic. It's changed. There are updates to these frequently asked questions weekly. You know, you ask, what does the bill look like? You could find the bill and the rules right on the website. We have a helpline. The people are there to answer questions.
You haven't been to their website?
So I'll afterwards. I'll have the information for you. But John, why don't you?
Yeah, I was just going to throw my 2 cents in on the legal aspect.
Thank you. I'll take as many cents.
This is not a shot across the bow of the VCF, but I think John hit on it. Like, only now do I feel like we're kind of getting somewhere with all of these systems. Because when they started the program on October 3rd of 2011, trying to weave your way through that program, I mean, it was a quagmire to say the least. You know, even now, I mean, if I had a client who came to my office this afternoon and wanted to file today, I love the website, go to the website, it's got a lot of great information on it, but to file your own application online, and they'll tell you directly, it takes 11 hours. It takes 11 hours to fill out the application online.
More than that.
We have the same.
And generally speaking, that's what they say. My office takes 11 hours, and we do that every day. For somebody who's just sitting at their computer for the first time, sitting down and putting in their information about themselves, it's going to take a hell of a lot longer than 11 hours.
It's the same thing in my office, where in my office I see patients on consult from the program.
Right. And
the program's office suite is 3 doors down, but I just can't direct my patient to get an appointment in there. they have to call a 1-800 number, and even though I know the doctors, so there's a lot of bureaucratic obstacles.
You're a fool to think that you could do this by yourself, and we tell that to
Yeah, I mean,
respondents on a
right.
daily basis. 8 to 10%, it's less than 33%, and again, this is the rest of your life. So what you might fill out and might think is right, you might be shortchanging yourself a larger reward if you have a
Maybe
way
it
to
has
do
to be
it.
appropriate.
There are a lot of good lawyers, good firms
Yes.
out there that are doing the good, you know, a good
Who
job.
is your lawyer? Because I could comment, they can't.
I'm not sure, and that's sad, but that's
Right,
a little.
okay, well, you know, here's a problem with a lot of law firms, and no offense to this
Listen,
law.
they advertised,
Yeah,
they said,
sure.
hey, oh, Napoli Burns had you
Right,
you
and
initially.
they're spawned from the devil. Okay, so with that being said, some law firms, I'm not gonna retract what I say, but some law firms are representing 300 people. Some law firms are representing 1,000 people. Some law firms are representing 6,000 people.
Wow.
So, while the 9/11 responder comes to my law firm and I got 6,000 people, you're gonna get lost in the shuffle of the paperwork, and you are gonna be seen in about 9 to 12 months from now. Somebody's handling 100 people or 200 people, your paperwork's gonna go through a lot easier. Come back to the BCF, they have a problem to let you know, it gets filled out.
Right.
So a lot of these law firms, listen, when the bill passed, the day the bill passed, December 22nd, 2010, there was law firms posting in the media already. The paint wasn't even dried on the wall yet.
Yep.
And I was commenting in the media about that. Here's the thing, after the bill passed, I'm afraid, were you in that meeting when I was asked to come to DC with Brian Howard?
No, I don't think so.
About 2 months after the bill passed, the DOJ called me, and I thought I was in trouble. I really thought I was going to jail. And they said, can you come to DC? We want to talk to you. And I sat there with Brian and a bunch of other people, and they picked my brain for about 4 hours. And I was like, oof, God, I'm not in trouble. But they also said, well, we're expecting 30, 35, 40,000 people. And my exact words to Brian was, you're smoking crack. I'm telling you right now, you're going to get 17 to 22,000 people tops. Tops, that's it. So when the bill was passed and it got chopped up, it came down, we had $4.3 billion. 2.7 for healthcare, for compensation, 1.5 for the healthcare. Everybody's, well, this isn't enough money. We don't have enough money. There's not going to be enough money to come. It is enough money. It is enough money. And to prove that, they have awarded 39 cases so far at over $5 million. And that is being generous. And again, Sheila and her team, with the cards that she was dealt, is doing an amazing job. And because I crunch numbers and I'm like Rain Man, right now they're hovering around 17,000 people and change that have registered.
Yeah, over 18,000.
A little over 18 now, right?
How did you know that?
Okay.
How did you guess that?
Because for the last decade, you know, if you break it down from state to state, if you see how many people LHI, the National 9/11 program in Wisconsin, they're doing about 12,000. Mount Sinai's doing about 12,000. Robert Wood Johnson in New Jersey is doing a little over 2,000. Stony Brook's doing 6,000. Not everybody who goes to these centers of excellence is eligible for that compensation. And a lot of them, because of their offsets, they're not going to get anything but the $10,000
Yeah, I mean,
that shield.
Right, but it's right on, you know, this is information,
Billy's
it's right
fine.
on the web.
Trust me when I say Billy's fine, and I'm not going to do it in front of him because it's disrespectful to the VCF, but I can gauge what Billy would do because he was in uniformed services in the ESU and what his illnesses are. Yeah. So I think now that everybody knows that the bill passed and everybody knows that there is a carrot being dangled in front of them, the anticipation and the post-traumatic is spiking because everybody wants that money. It's the rest of their life.
I know Julie wants to ask a question, but I have an important question to ask, which is where are the physicians in this? I see a dozen officers every day. Most of them are not in the World Trade Center monitoring program. They've heard about it. I don't think I should take because I wanted it for other people who really need it. There's so many officers who don't even know this. And I certainly didn't know about October 3 deadline. So where
This information goes out. I mean,
but where do the physicians fit into this, or the students and doctors that
you know,
are attending these
let me
places?
just say, I had, you know, remember Julie and I talked about some kind of overview, broader questions, you know, to finish up with that I thought about. But I just come back with, I just want to make one comment about how the 11 hours. it's a challenge for us that we're asking for this amount of information, but I don't want to sort of avoid, there's a big box on the homepage of the website that talks about fraud. You know, we have, the fund has an obligation to gather the information to, you know, make awards to people who are eligible and deserving, to implement the statute the way it's supposed to be, and that's kind of a reality.
Before you reply, I think, to Dr. Ahmed's comment, I did want to tie in what Cindy was saying about how this has impacted them, this whole process. And I think we can tie in the doctors there as well, because as you said, the VCF is very, is integrated with the WTC health program, because it's the doctors of the WTC health program who fill out these forms when they examine the patients to say, we think that there is a, you know, that this condition is related to this person's specific exposure, and they request that NIOSH certifies that condition. And then that's something the VCF is using, that certification, in order to determine that they can, you know, be eligible for the VCF. And what happens is, and I think Dr. Karnick will have some comments here too, is the physician and the patient are here, and there's all these macro and influences that affect them, affect the patients, affect their families, affect the doctors, and how they interact with the patients. So I just wanted to broaden that.
Right, and first of all, the physicians, the social workers, the other medical providers at the health program play just a tremendous role, and we really are appreciative of that. I guess a couple of months ago, we did an information session for physicians and other social workers, providers, up at Mount Sinai, just to kind of give an overview of the background for for individuals, because I think we understand it's very challenging. First of all, we wanted to communicate how important the role of the physician is in the process for us, and just talk a little about how one writes up the diagnosis. I mean, it's helpful when it relates to the particular injury in a way. I mean, that's sort of one of the challenges. Sometimes the certifications may, the nomenclature may be different, but we're figuring that out. But I think one of the reasons that we were asked to come is that you as physicians have this lineup of patients outside the door. I mean, the role of the physician is not to provide technical assistance for how someone should fill out their VCF form. You don't have time, right? You don't have time to do that, but it's helpful. And I think this is just a great seminar, because from my point of view, to to have your patient and you're dealing with their physical or or mental condition, but what else are they dealing with? And in this particular instance, they're dealing with challenges of getting this done on the outside. And so at least to know what that is, I think it's helpful in the caring process.
Do any of the students have any reactions or comments?
I had a question, going back a little, Mr. Houston, you were talking about how this interaction between the medical field and the political field is complicated.
Yep.
And in medicine, I mean, we're student doctors, we're taught to practice evidence-based medicine, and looking at this study here, it seems to us eventually, if we consistently saw higher rates of cancer in these responders in the medical field, we would change our practice. But that's not how it really works in politics. I want to know about that process. You could speak to it, maybe Mr. Field as well. It took almost a full year, even after the drug bill was passed, to get the cancers included,
Right.
when that just seems so obvious.
Yeah, well, listen, one, Dr. Howard deserves a gold medal for getting cancer added to the bill in less than 2 years. Listen, most cancer studies 10, 15, 20, 30 years. So let's go back in time. The previous administration, I won't say who, the Bush administration, they didn't want anything to do with us, 9/11. They said we were crying wolf. They said we're making it up. 9/11 didn't make us sick. Whatever they could say, they did. The Bush administration hired Dr. Howard to be the 9/11 health czar. A couple months later, Dr. Howard was fired by the Bush administration for care. He was out of a job for about a year, and then Obama took office, and we did a press conference at Ground Zero. We made some phone calls, we wrote some letters, we advocated for Dr. Howard to get his job back. He got rehired.
Wow.
He got cancer added in that short amount of time, which is miraculous, Now, the 50 cancers that were added to the bill, I don't agree with all of them, but it's still 50 cancers. Breast cancer, there's 4 people that we know. Eyeball cancer, I don't know anybody with eyeball cancer. Prostate cancer, you saw the article yesterday, it's not added yesterday, it needs to be added. Brain cancer, it needs to be added. So listen, we don't carry MDs or PhDs, but we know facts and we know statistics. And after 74, 75 funerals in 5 years, and you see these men and women dying of these cancers, it doesn't take a rocket scientist to know this. So we're at a point now where I believe prostate cancer will get added in the near future just because of Dr. Howard's body of work.
What is that process to get something with NIOSH?
I was going to say that there is a process.
Okay.
But the centers of excellence, and that's where the physicians come into everything. Again, we're all catching up to each other now. The physicians, they have to give a report on the individual responder. They take these statistics, they take these facts, and then NIOSH implements whether these things are going to get added or not. So again, this is why everybody needs to work in unison, because at the end of the day, if the centers or the BCF or NIOSH or the elected officials aren't working together, then it's the 9/11 responder that suffers. And that's where we come in.
No, I just say, so just the process, again, if you go online, in the Drograph, you would see there is a scientific advisory panel that makes the recommendations.
Now, just to answer from a legal perspective, the VCF takes a lot of the, once you can get something to a point where it is accepted, and a lot of that is political. If you had more of a conservative or more of a non-New York type of delegation that was really banging over the heads and saying we're not adding this stuff, we could scream in the wilderness and it may not do any good. Thankfully right now we kind of have winds in our on our back. In the other areas that I practice in, due process takes over. And what happens is I'm fighting with a retirement system that doesn't want to pay somebody a 3/4 benefit. I'm fighting with an insurance company that doesn't want to pay somebody a benefit. Most physicians are altruistic and are trying to do the right thing. But trust me, these insurance companies will hire, doctors to say whatever they want. And ultimately at the end of the day, that's what you're fighting against when you're fighting in these systems.
You're often fighting against the health professional's opinion?
I mean, look, up until just recently in the state retirement system, 9/11 related disability pensions were incredibly difficult. Incredibly difficult. Only once NIOSH started accepting the cancers have I started seeing a drastic improvement in terms of approvals for cancer-related pensions. Most of them over the first 10 years, to go back to the PTSD discussion, most of the 9/11 related disability pensions that I was winning, I won on psychological grounds, not on physical impairment grounds.
That's why I sent the number.
Let me just give you some statistics. Individually, I was denied Social Security disability after losing half of my foot. 11 weeks in the hospital, 30-something surgeries, and Social Security denied me. I was like, you got it now. Right? What do I got to do, right? Anyway, when I appealed, I won. And I won because of my post-traumatic. They told me I was off the charts crazy. They said, this guy, I'm not kidding. You guys still have it. I should have framed it. They told me I could not be in the workforce. They told me I was disruptive, and rightfully so, but I was off the chart crazy. They did their tests on whatever. But what was 90% of the 9/11 community, and Glenn's one of them, applied for Social Security, get denied. 90% of them that appeal win. Right.
Why is that?
The appeal process takes anywhere from 12 to 24 months. But what we do now is get their congressman or Senator Jill or Brenda Schumer to call Social Security on their behalf, and their appeal process gets expedited into 3 or 4 months. So that's what we do for them. Let me just one more. The workers' comp. you could have a box fall on your head at Home Depot and get workman's comp faster than 9/11 responded. Now workman's comp is over, you can't file for it anymore.
Correct.
But in 2005, before we got famous for getting this droga bill passed, there was a thing called the Walsh Amendment. And this is in 2005. And the White House, at that time, took $125 million back from New York State workman's comp. They took it from you.
Yep.
We gave it to you, and we're taking it back because you weren't using it fast enough to comp 9/11 responders. So we did our lobbying thing there. So we actually, that was the first bill that we helped get passed. Senator Clinton at that time got it added to the emergency spending bill. But workers' comp, Social Security, pensions, Glenn's been denied by his pension board 4 times now. So 5. So it's an uphill battle every time we have to go in front of anybody. And these aren't benefits which is going to get you a pool built in your backyard. These are benefits that are going to put food on your table, right, because you're not making what you used to make. You're only making a part of what you used to make. And hopefully it puts food on the table to feed all 4 kids because you got a lifestyle. Or put gas in the car so you can get to your chemotherapy appointment. So the problem with 9/11, since 9/11 happened, as we get, is the sensitivity to all issues regarding the 9/11 community. It's all about sensitivity.
What do you mean?
Well, I'll give you a perfect example. A couple years ago, they flew Air Force One over New York City, and it spiked a lot of people's post-traumatic. No one took into effect that thousands of New Yorkers suffer from post-traumatic, and there was a lack of sensitivity. These articles that come out, well, it's great that we have a 15% increase in these, but we're not going to add prostate cancer. Yeah, the sensitivity towards those with the prostate cancer is not there. We're working on getting prostate cancer added to the bill. We can do better to get prostate, and maybe we'll use different role models to find ways to get cancers added to it. Right now, the only role model they use is epidemiology. And epidemiology is done in a clean environment. 9/11 was farthest thing from a clean environment. And they have to figure out other ways to study these cancers.
Can I take what you just said, which is really
Most people.
a crux of the issue with determining what is covered and what's not covered, is that our science isn't perfect for this particular situation. We weren't prepared to measure the exposure the way it probably needed to be measured in order to make those correlations that we really would like to make between exposure and disease. And I think that's why, and I want to bring this back to Dr. Karnik, because he's been thinking of some case studies he can share with the med students to kind of illustrate this, is that the physicians in the middle is trying to take the personal story of exposure and link and make the decision about the link to what's being experienced in terms of health conditions of the responder and certify it. And there's a lot of programmatic rules and interpretation of the law that the physician has to work within. And it may not always be so easy when you have a patient with you trying to make decisions in your care for the patient. So can I turn it over to you a little bit?
You know, we have been talking about different funds and certification and so on. So I just wanted to really give you some examples of the dilemma that we face every day in the clinic. You see, as a physician, my job that's therefore rather simple, in the sense that I'm the best advocate or one of the advocates for the patient, right? That's all of us want to do. And that's all I have to do. And if that was it, that was my responsibility, it would be very easy. But because of the nature of this problem, I have to work within certain bounds and follow certain guidelines, certain parameters. And at that time, the conflict arises and dilemma arises. And what really happens is, patient may, to illustrate this, I can divide the kind of cases that I see into, say, 3 groups. One is a very straightforward case which has very clear-cut cause and effect or temporal profile of relationship with the exposure at 9/11. The patient was there for a long time. He started having symptoms within a reasonable period, and it's very straightforward, and we have no problem saying that this is related to exposure there. Now, the other kind of cases are something which is borderline, and that's where the problem comes. Now, what makes them borderline? These patients have a rather longish sort of period when the symptoms started. The patient was exposed, his asthma didn't start for 7 weeks, or his GERD symptoms didn't appear till 10 years back, or have occurred now. So it becomes very difficult to decide whether it is really related to that. In that situation, we have to use our clinical judgment and find out. And other kind of cases are very clear-cut cases that are not related to 9/11. I'll give you some examples of these things. Now, the rules of the games have been changing from the time we started. And as Julie mentioned, I've been seeing these patients even before the federal government grant came in. In our hospital, we started seeing these patients on a voluntary basis almost in October or November of 2001. And so we have had experience from that time onwards, and I have seen the pattern of disease changing, pattern of parameters, guidelines have been changing. For example, initially, although these were not really spelled out, initially we could certify a patient as RAS, reactive airway disease syndrome, who started having symptoms within 5 years. If it was after 5 years, then it was not connected to the World Trade Center exposure. So that seemed reasonable, although it is difficult to imagine that if a patient really had exposure there, his symptoms should have started immediately after that. Why was there a latent period of 5 years? But we said that's fine, that's not split hair. If government allows that, let us give the benefit of doubt. But that sort of guideline, there was no fixed guideline, but that was conventional that, within 5 years. Now that parameter has changed to within 1 year.
Oh, look at that, narrowing the window.
Yeah, within 1 year for GERD, a couple of years or 2 to 3 years for asthma. Now these were never spelled out as guidelines. So the decision was clinical, and in the beginning it was very easy. Then once the Droga Act came in, they started asking us for certification. And what certification means that we have to follow these guidelines and say that in my opinion, the patient's illness is related to 9/11 exposure, therefore I want the patient to be certified. So this is how the things have changed. Now, as I said, in clear-cut cases it's easy. You have documentation from earlier on, the patient was treated by a pulmonologist or his own general practitioner and had, was given Advair and whatever, and you have convincing evidence. There are some cases which even visit once are coming now, and it is difficult for them to reproduce all the evidence because it is so far back, about 11 years now, that they do not have a exact memory of when the onset occurred. And when we want to certify, they want us to write exact date when the first symptom appeared. Now, which patient, you can think about yourself, when did you first have your cough? Or when did you first have your blocked nose? It's impossible. And a lot of times patients either treat themselves over the counter, and even if they had gone to the general practitioners, there's no evidence. It is something they don't preserve the prescriptions and so on. So these are the cases which make it very difficult to really certify. There are certain situations where we feel that it is probably not, as a clinician, that it's not really related to World Trade Center exposure. For example, yesterday I had a patient who was very unhappy because I didn't prescribe medications for his ED, for erectile dysfunction. He was very upset. He said, one of my other friends is getting it, how come you don't give it to me? And I had to explain everything in detail, that the other person's ED is related to perhaps his psychiatric medication or his psychiatric problem. Well, he wasn't convinced about that. Now, similarly, patients now, respondents now hear that the other person is getting treatment for GERD. So he says now, I have symptoms of GERD, can you prescribe Lexington? The problem there is that if you look back on his record, he has never mentioned a GERD as one of the problems. Now what do? The patient does have symptoms of GERD. How do I support him? I tell the patient, listen, I'm going to be your advocate, so please give me as much information as possible, which is documented so that I can plead your case with the government. That's how I put it to them. But they don't have all the records anyway. So these are the cases which are difficult to certify.
But Dr. Karnik, don't you see the opposite? I see patients who have had symptoms for a long time and are averse to coming into the monitoring program. Right. That's what I mean when I say a dozen officers a day.
Yeah,
I don't mean registered in the program. I mean, that's their job. and then you happen to ask, or it comes up by chance, now I make it a rule to ask everyone about 9/11 exposure, and I discover all these patients, and they don't want to, they feel they shouldn't or they don't deserve, but they have at least 2 or 3 conditions.
Yeah.
So then my bias affects the console. Then I'm searching for these conditions, and I'm sending them, if they would listen to me, to your program.
Yeah. I mean, there are certain conditions which are left out. For example, mild sleep apnea syndrome. Patients may have severe symptoms which interfere with their work or driving and things like that, but mild sleep apnea is not covered.
That's very arbitrary.
It's not covered. So you remember we initially had that dialogue going on, why can't you cover this? I said, I have to work within the parameters and guidelines set by that owner. And we have to remember one thing. I mean, all of you are aware of that. Medicine is, although evidence-based, as you mentioned, it's not an exact science.
Yes.
I have seen patients who have symptoms of GERD, but their endoscopy is normal.
Yes.
Now, there comes the question about body and mind reaction. This patient has PTSD. He has symptom of GERD, which you cannot document. Endoscopy is normal.
Right.
Do you deny him the coverage? Because
No.
he has no hard evidence? No.
We treat our patient, not our symptoms.
Yeah, exactly. We treat the patient, we treat the man behind
Not
the
the
patient,
endoscope, yeah.
not the lab.
But there is so much emphasis on evidence now in a way that didn't exist when I was a medical student. Not because there was a lack of evidence, there was a lot of evidence, but it's taken on a very powerful role. And sometimes people become blind because it doesn't match the evidence they know. And there's almost no evidence that is not with some sort of bias or some sort of
We get 9/11 responders that come to us every day. Look, I get 200 emails a day anyway, and phone calls. And Glenn will attest to this. 90% of 9/11 responders now all say the same thing. My doctor's never seen anything like it. I have the worst GERD in the world. I have the worst asthma ever. They want to be sick. They did a point 12 years later that, well, I was in my lawyer's office and he looked at my medical records and he said he's never seen anything. Dude, you got GERD. 90% of America has GERD. That's why there's an antacid commercial every 5 minutes. You eat Taco Bell, you get GERD. You know, GERD is a serious illness. I suffer from it. I take apple cider vinegar. I choose not to take Nexium. What I'm saying is that these illnesses that are covered under the bill, they want to have the worst one, thinking that they're going to get the biggest payday.
That's one, maybe that's your experience, but the other thing is people, and physicians included, minimize diseases according to their names. So a great example is something called Ekbom syndrome, which sounds terrible, which is the same as restless leg syndrome, which some people challenge as whether it's or not a real condition. And restless leg syndrome has the same impact as depression, osteoarthritis, diabetes, and a number of other chronic conditions that everybody recognizes as serious. So the thing with GERD is you often see patients feel ashamed to tell you about the symptoms, but they're waking up at night, they have voice changes, they can't enjoy any food. It really debilitates them. So some of the bias comes, I think it comes from uninformed health messaging.
At 12 years later, if you really haven't got a grasp of your new lifestyle, you're going to have a problem in 12 years from now also. Listen, none of us are the same people that we were on September 10, 2001. And we were dealt cards that we might not have wanted, but diet, exercise, taking the proper nutritions, getting a good night's, whatever. I mean, I sound like Hulk Hogan, eat your vitamins, but what I'm saying is you have to adjust to your surroundings. And you, whether it's your lifestyle, the way you live, you have to downsize, you're not living in the, you don't have 4 cars anymore, you got 1. But what I'm saying is you have to take care of yourself too. The doctors at the WTC clinics can only do so much for you. They can't watch you 24/7. You have to go home. Me and Glenn were in the gym for an hour and a half this morning. You know, I'm there with I just had knee surgery and hernia surgery. Glenn's got more things wrong with him than most 9/11 responders. You're not going to hear him complain. What I'm saying is that you have to take care of, you not only have to take care of yourself, you have to advocate for yourself. Your lawyer's not going to be there for you all the time. Or the BCF's not going to be there to hold your hand. You have a responsibility like you did on September 11th. You made a conscious choice to go down there. Now you have a conscious choice to advocate for yourself and to take care of yourself so you can live long enough to see your kids get older. And I'll say that to anybody.
Can I interrupt and just bring some of the online comments in? Because I know we have an audience out there, and I do want to include some of these comments. One that just came up recently was from New York Islanders, Fanning Alley. He wants to say, excellent insight by Dr. Ashok on the clinical dilemma. Can the panel speak to the long-standing studies that have been ongoing since 9/11 on these issues, which were used to bolster the policies in the bill? So I think this goes back. I think, Fran, you had said something about the STAC, which is the Scientific Technical Advisory Committee that.
Well, and NIOSH.
Of NIOSH.
Right, in terms of the decision-making process of how they
really
add conditions.
Informed the policy making, right? This data we've been collecting through monitoring visits over the years and the papers that have been published.
Well, right, and I mean, John, I saw you there. I mean, I don't know, John, you said whether you were there, but there were at least 2 days of all-day, hearings at 26 Federal Plaza. I was sitting in. That wasn't our role in listening, and a lot of public commentary, advocacy from scientific groups, claimants, responders, etc. They're not easy decisions, again, because of the nature of the science, and again, the physicians. You have a hard job. This is not easy.
Not as hard as the patients.
You gotta remember, 9/11 affected everybody, but everybody's different. We all share the same common, 9/11 changed our lives, but everybody is different individually. Everybody's immune system is different individually. Everybody was affected differently, but still affected by 9/11. And that's where it's up to the doctors and the scientists and NIOSH and the DCF to do their job.
Joseph to read his question, because it's important to this
I
discussion.
think your comment is very important, because last, one of the earlier sessions I had mentioned that it's like seed and the soil issue. You see the same toxic products in one patient will give him debilitating asthma or GERD. Another patient will have no symptoms. So this is one factor which varies from patient to patient or respond to respond. And second thing is the mind-body reaction. The same degree of GERD, one patient will feel it's a horrible thing that is happening to him. Other person will say, oh, it's nothing, I just take tongue swells and all. So how much reaction you have to your physical symptoms depends upon your own concept, or your higher function, which sort of dictate how you perceive that symptom. So I think that is now these two things are both very variable. And we just have to use our own clinical judgment to decide what to do with your patient. But yet, I think the most important thing is that we have to listen to every single patient, take every single complaint very seriously. Because again, he's describing a symptom in his own body. And I have to look at it in the best possible clinical way and in the most objective way.
Joseph is one of our student leaders for day, and he came up with a great question. I think that tries to get at really the role of the physician. Is it the role of the physician not only to just treat the patient in front of them, but also advocate for them?
Which page is
it's
page
on page
2
of our agenda for today. And I think it really gets at how far does a physician is a physician obligated to go for the patient? And this is a perfect. Looking at the World Trade Center Health Program and compensation is a unique program. It's a really important
one. They're not only our doctors, but they're also our advocates.
Right. So can Joseph
Sure. Well, I started the question with a quote from my father, who was a physician at Mount Sinai, who helped establish the screening and treatment program there. His name's Steve Levin. I don't know if you've heard of him.
Your father was a great man.
Oh, thank you.
Amazing.
Yeah, thanks.
And he did more for workman's comp than anybody ever in the history of the state. So
I appreciate
God
that.
bless him.
And in the reading, in one of the reports, there was even his testimony there to Congress, telling what he saw in his clinic and things like that. He said, science and facts alone don't always change what happens to people, but when people use these facts in combination with political means, big changes can result. He wasn't specifically talking about 9/11 there, but more so improving workplace conditions through research findings and such. But I feel it does have, it is relevant to the Droga Acts, certainly. And my question is it our responsibility as physicians and future physicians to politically advocate for patients when possible, or is this an expectation that is above and beyond the call of duty? So,
Absolutely.
I open this
guys
up
have a
to my colleagues
responsibility.
and also physicians.
But he just brought that up in his last comments. You guys have to take down every note, whether it's somebody who's accentuating their illness and fabricating something, or somebody who has a legitimate illness. These have to be documented, and then you have to use your best judgment to advocate for those illnesses. Because if you keep adding that up, you might find an illness that's not covered, and there might be a trend where they have to look at something, and that illness will be added. You know, if you take every toxin that was down at Ground Zero, and you individually put them in a bottle, you'd have a skull and crossbones that say harmful to swallow, consult a physician. Then you take all of the toxins that were down in Ground Zero and you put them in a jar, you got a toxic soup that no one's ever seen. You didn't go to school for 9/11. No one did. No one was prepared for that. It's unprecedented. So you got all of these toxins, and through the absorption, through the nose, mouth, and skin, you have to give us the benefit of the doubt. We no longer have to prove, and I'll say this, I said this to elected officials on the Hill, we don't have to prove anymore that 9/11 made us sick. You have to prove 9/11 didn't make us sick. Why do we have, and I'll say this again, why do we have centers of excellence? No one's ever apologized for getting us sick at 9/11. No one's ever stepped up, manned up, and grew a set of Abe Lincolns and said, look, we're really sorry you guys are sick. But they did create centers of excellence. And we have those centers of excellence now because that's their way of saying, sorry, we got you sick, now these men and women are going to treat you. So.
So just, I think that, you know, no matter what field you're in, as a professional, a physician, you know, a lawyer, a professor, you know, an engineer, people make individual determinations beyond their specific responsibility to their client, their patient, about how they're going to engage in the outside world. And you see people who, you know, physicians who are, you know, excellent physicians in terms of caring and treating their patients, and their, you know, sort of view engagement is focused on that. And then you see people who are more secular and wear, you know, more you know, global hats and engage in every field. And I think, you know, some of the questions that I have in terms of, you know, broader critical thinking beyond 9/11, just in terms of the role specifically here as you know, physicians, is you know, what should you do to make yourselves aware of, you know, environmental, sociological events that impact on the health of your patients, whether, you know, you're treating them as, you know, as in the areas of your expertise, but, you know, your patients are human beings. They interact in the world outside of the office, and that level of awareness, I mean, interacts. I think that with physicians say, you know, I'm very fortunate. I have good physicians, you know, who ask, so what else is going on in your life besides you might have a pain? What's going on? I think it's important questions, and, you know, as you complete your, you know, your training and you go out, you know, to practice individually, you know, what kind of techniques are you going to develop to, you know, you create and use, you know, broader critical thinking? It's very important in this world today.
What do you think the answer to your excellent question is?
Well, I for one never
Sounds
imagined
like-
as a future physician really being involved in the world of politics, but I understand that, you know, something like 9/11 happens and all of a sudden you find yourself swept up in it. And I think it is a responsibility of us to sort of be prepared for these
things.
things.
It's in your blood.
Yeah, I mean, well, yeah.
Listen,
That's certainly
you know, for those
true,
who really
but-
don't know,
Yeah.
his father was a pioneer in the beginning, and he did what Dr. Howard did now, and it's probably not recognized by those who are getting into the game now in the 9/11 community, but what his father did for us in the 9/11 community is nothing short than amazing.
Thank
so, you know.
I want to add, there's a comment online directly related to this, and it's something that maybe the students can think about and ask. Do you think that becoming politically active undermines your scientific objectivity? you know, I'd like to hear from some of the students what they think about that, if it creates a bias towards how you may view your patient. Is that?
I just want to add something to what John just ended on. Is I want to learn. Joseph, sorry. I want to learn more about your father, Dr. Levine. But the thing that I'm hearing is, number one, the most effective advocacy for all of these strategies for looking after 9/11 people, patients and families really came from what we would say are patients or civilians. And the civilians kind of led everybody else along, including the physicians, so that they formed a very effective public advocacy group. The things I've learned from my patients that are in this program are very different than anything I've learned from other patients, because I have more of an interest. So there's a real opportunity for doctors who want to become politically effective, especially if they're serving this kind of public good. But the other thing that strikes me is how the doctors that helped you or supported you, like his father or the other gentleman, ultimately were very supported by their patients in return, by the way you're describing the reappointment of Dr. Howard.
Sure.
So it's really, one thing you'll learn as you become a physician is you think you're going in to make other people better or heal other people, but you often end up being the recipient of healing or other benefits in a very unexpected way.
But when we were trying to get the bill passed, we go through committees or hearings, and you know, if one of us got up in front and spoke in front of a congressional hearing, it's us telling our story and humanizing it. But when Dr. Levine got up there and gave them the facts and the statistics and the numbers, it's a licensed medical expert giving him the facts. And sometimes you can hit Congress over the head with facts until you're blue in the face and it doesn't work. But in this case, it did help, because it was a trend that started where other physicians came forward and they did get political. And you know, it's frowned upon, don't get political, blah, blah, blah. But it's in the human nature to be political, because once you see wrong and you want to make it right, it becomes political. That's just the nature of the beast.
That goes to your question.
To answer that question, I think doctors are asked to be objective every day. And while I'd say I don't think it would be sacrificing our scientific objectivity at all. As long as you are pursuing what you think is right, you're not going there with an agenda. You know, I'm not finding my agenda and finding the scientific facts to fit it. That would be wrong. But if I'm just learning the facts and going and telling them what I know, that's absolutely part of the job.
I want to bring up another question that came up online. It says, how should physicians communicate with one another so that new diseases can be recognized in the Zadroga Act? If I'm a physician and I see 10 9/11 first responders and 4 of them have the same illness, where should I go to see if other physicians are seeing the same disease? What are the HIPAA requirements for this?
One, check your ego at the door.
Well, I think there's a question here for like the physicians. Do they have the right, I mean, how do you, as Dr. Ahmed said, she isn't aware of things like the VCF, you know, certain things about the VCF. And especially if you're in private practice, you're not always integrated with each other, and yet you may be all seeing patients with similar issues. And how do you, is there a way to communicate that? And
Got a central data bank. You guys keep in touch. Put everything into one central
right, so we have a cancer registry for New York State. So I mean, we do that for cancers. Maybe there's other, you know.
Yeah, but for years, and I'll say it because I don't care, for years the centers of excellence didn't play nice with each other because there were egos.
With these patients?
With patients in general. So maybe Mount Sinai didn't get along with Outlandia, or Robert Wood Johnson didn't get along. But again, we're at that point now where everybody is finally, after 12 years, finally getting it right. It's never too late to get it right. And I think we're at that point, and I think things will run smoother in the near future.
And just to say, we have a data coordinating center for those clinical centers of excellence. So all the data that we collect in the visit becomes aggregated at the data center, in which case all that data is used then, you know, as long as people consent to have it used for research, it's used to try to understand these issues, and that comes out in papers.
That's like a nice.
Is there an annular?
So there is a, but that's only for people, of course, that are involved with the clinical centers. There's a lot of people, as you mentioned, with patients that go all over, are not involved with the program, And, you know, for those physicians, you know, where do they go? I think is
Other thing that we tend to do is to really contact other centers of excellence and talk to the physicians, especially if we come across a very rare case. Have they seen something like that? We have had cases where a patient had two diseases, sarcoid and another granulomatous disease, which is very rare combination. So we reach out to other centers, have they seen this kind of thing? Similarly, I have a patient who has myositis and motor neuron, some kind of muscular dystrophy. And those are, it's very difficult to understand whether they are really related to the exposure there, has somebody else seen. Because if you see that these cases are also being seen in other centers more often than usual incidents, then perhaps you have to start thinking whether they are really related or not.
I want to say,
I just want to ask Julie, I'm surprised, first of all, I'm surprised they don't have a central data bank where you put all the information in, which includes centers of excellence and LHI for the responders all over the country.
There is a data center for the Border Trade Center Health Program. There is a central data bank. But I think the question is for people who are not involved with the centers. Other physicians, private practice physicians, they're not inclusive. So unlike the cancer registry, which is for everyone, public, it's for all the physicians who diagnose cancer. Ours is limited to the people who are involved with the program specifically.
They should be doing a memorandum around to all the different hospitals. I mean, they do it when there's a health alert that the bird flu is out now, and what to look for. Why can't they do the same thing? Please provide this information regarding 9/11 responders for people who are exposed to the toxins, and please enter it into this data bank for us so we can file information and see, we all know that the common goal, the common thread between all 9/11 responders is sick as we breathe in toxins. So this is really basic. That's the thing. But to do something like that, it gets political. And while NIOSH is doing an amazing job, NIOSH is also run by the CDC. CDC is run by the Secretary of Health. Secretary of Health is run by the White House. So I mean, when does it stop? When does it not become political? Because again, at the end of the day, it's all about helping those affected by 9/11. Like I said, they do a lot of things on paper seem simple.
No, I was just to say, it's everything. We live in a world, everything's political. You may not realize it, and being political isn't necessarily negative. It just, I mean, you as physicians, you may say, oh, yeah, I'm treating my patient. Every professional engages in this world. Very few people work in an isolated situation. I mean, you'll all be, affiliated with hospitals somehow. And you'll advocate for some, for resources. It may not be electoral politics necessarily unless those resources, impact your advocating with, governmental agencies. But it's not a bad thing. It's just the way the world is, and people, everybody has value judgments, their own value system, and that's what you have to recognize. But for me, I always think about it as an opportunity, that there are issues that are important to you, and we all maybe you sit on different boards. There are opportunities to advocate for issues that are important to you, so that just one earlier question was, so what, under what avenues, what panels, what professional organizations should we advocate for those issues? And I think the answer is all of the above. It comes back to critical thinking. What are those advocacies? And
that's
just this process, again, this this seminar, I think it's a great opportunity to talk about those developing those kind of mechanisms.
But this is where what I think my colleague was saying, a doctor must always be objective and doesn't come with any agenda. So that's true. The objective meaning you're looking at the disease process and finding the best treatment. But once any doctor that decides to become an advocate for anything, whether it's let's get more flu vaccine, you have already made a commitment to a particular outcome. And you know very well you can find data that will very much support your argument, and you'll be able to dismantle data that challenges your argument. So I don't know if you remain objective if you become involved, but I think being involved doesn't harm your clinical.
But I think medicine and science are different than a lot of other fields where I can stay objective and have one opinion, but if somebody presents me with research that shows the opposite and it's significant, I change my mind. And I don't think that would be necessarily sacrificing my objectivity about a situation just by having an opinion about it formed by research.
Well, you're going to be a good doctor.
We're actually after 3 o'clock, which is the time that we end, but I didn't want to leave this discussion with that. If anyone has outstanding questions that they have, or any of the students we haven't heard from, if you want to comment on something you've learned today that you find helpful or interesting, I'd just like to, open up for further questions.
Or we could blog it.
I have one question. If nobody has a question, my one question is to you. Is that if you are going to get ready to re-extend the bill in 2015 or 2014, what can we as physicians taking care of World Trade Center first responders start doing so that we can contribute to, do they write a new bill or they
Tricky question.
What kinds of things can we start
You guys
doing?
are limited because you receive a grant from the government that you cannot really lobby for the bill. You can go to DC and you could show your support. Dr. Luck did it. But you cannot actively engage in conversation with those elected officials and stuff like that. Does it help to write a letter? Absolutely. Does it help to call an elected official's office? Absolutely. Can you tell your friends to do it for you? Even better. But the way the bill was written, centers of excellence, the physicians are, they hand it tied. Hence, listen, if I never got hurt, I wouldn't be here right now.
Your center of excellence, you can't lobby.
What we did was do what nobody else wanted to do. And not because we had to or we wanted to, because nobody else would. And it grew to the point where it got bigger than us. And if we stop, there's no one else that's going to be willing to do it 12 years later, so we continue to do it. Don't get me wrong, if I wasn't here right now, I'd be golfing. I'm telling you the truth, I'd rather be on the golf course than sitting here, but we now have a responsibility. Elected officials have a responsibility. With power comes responsibility to help your constituents and to do what is morally right. And we have that responsibility now to help the 9/11 community to the best of our ability. And when we feel like we can't do that anymore, we'll step aside. But until somebody proves us different, we continue to do what we do. But again, going back to what we said before, it took us 12 years to get this close to everybody working in harmony. And while we might not ever be perfect in working in harmony, we're damn close. We're closer than we were last year, we're closer than we were the year before, and the centers of excellence have finally got a grasp on what they're doing. You got to keep in mind, before the bill was passed, the centers of excellence were working on a yearly budget, and that was painful. That was painful to see everybody scrambling. Well, I can't treat you for, I can treat you for, I can't do this. Now the bill's passed, and you have a little more leeway to do things. But everybody suffered. Even besides the 9/11 community, the responders, the volunteers, the doctors suffered, the physicians suffered, the lawyers suffered, because there was so much uncertainty. And now everybody has a little more clarity, and everybody has a little more facts presented in front of them, and everybody could do their job that much better. And that's what it's all about. If you can't share information with others, and you can't check your ego at the door, then you're not going to help anybody. And then just send them to us, because we will put our foot in their ass.
So on that note, I'm going to end the class.
Was it the answer?
And just keep up. I have a couple of handouts here for you.
And there's Fran has some materials. And I hope all of you are able to join us next week. I know we have some people online, and I want to thank you very much. Next Wednesday, Sunday, May 5th is the next seminar. And I thank you for your input, and we will continue this online. Thank you.
Live and what information where it's your time to realize that government is like,
Yeah.